Ada meeting ID-nya, Dok? Ini dia udah mulai. Hello, good evening, Yamada Sensei. Can you hear us? Okay. I think that your microphone is still off, so if you want to test your microphone, maybe you have to unmute yourself. Sensei, we cannot hear you at the moment. We cannot hear you. So please, okay, has to unmute. Can you unmute your microphone?
Yes, I hear your voice. Can you hear? Can you catch me?
Okay.
Okay.
Oh yeah, okay, I can hear you.
Hello, Dr.
Yes, yes,
Yamada.
yes.
Hi, nice to meet you.
Yeah.
Nice to meet you.
Long time no
Nice
see.
to-
Yeah.
Yes. Long time no see, Sensei. Maybe like 2 years ago, maybe.
You now working in neurosurgery, right?
Yeah, not yet. Right now, I am becoming
now resident?
research assistant in neurosurgery department.
Oh,
Not yet,
really?
not yet.
Yeah, but you already get a medical license, right?
Yes, yes,
Oh,
yes, yes, yes. Okay, maybe please wait. Maybe you can say while I'm still trying to add another participant. Maybe could you please wait a minute?
okay.
Okay.
Dr. Yamahata, how are you?
Yeah, I'm fine. How are you?
I'm fine. Thank you.
Oh, your cap is good.
That's a hospital cap. Yeah, don't worry.
Oh,
Just hospital.
operation? Oh,
Yeah, just hospital cap.
ah, なるほど. I see. I see.
Like
Your
let me
name.
show you
Yes,
here.
I can see your name. Yeah. How's your COVID-19 in your country?
It's terrible.
Terrible.
So many cases here.
Everybody wearing a
Yeah,
mask.
everybody wearing the mask and extend the distance. So social distancing.
Yeah,
We
yeah.
are in hospital just doing our job,
Uh-huh.
do what we can do. Anyway,
How about your family? Your
my
wife
family
and
is nice.
children already going
Yeah,
back?
yeah, going back. We are staying together in Semarang.
Mm-hmm.
Someday you have to come to Semarang. Anyway.
Mm-hmm.
And how about another sensei there?
And other doctor?
Yeah.
Everybody in good health,
Oh, that's good.
like Dr. Fujio.
Okay. Wait for another participant.
Ini url.com and spine. Bisa kok.
Problemnya di mana ya?
Saya bisa sih dok buka. Baru mungkin. Makanya kok partisipannya kok dikit banget. Saya lagi ngecek. Oh bisa sih dok. Ayo dok. Saya mute.
Dr. Yamahata, is it okay to waiting for another 10 minutes?
Yes, okay.
Yeah, wait. Maybe some problem with the link because anybody also contact me about the link.
Okay, the lecture will start 18:10 in Japanese time,
Yeah,
right?
yeah.
Okay. Hello, Judith. Hello, Judith.
Hello, how are you? Why?
You are permitting and attendant now.
Yes. I'm submitting, but maybe some problem due to the link and
do I have
they are
to
trying.
do I have to permit the attendant?
No, you don't need to permit it. We will
Okay,
permit it.
Okay.
We will permit it. Hmm? Lagi operasi ya. Dan apa deh nanti sambil nyusun.
Okay, Yamata Sensei, could you hear us?
Yes. Okay.
Okay, maybe we will start. Okay, maybe we can start now. Good evening, everybody. Dear Honorable College, Doctor, thank you for joining us in Neurosurgical Lecture 2020. In this evening, we will talk about our main topic, spine. Today, we have two speakers from first, Dr. Hitoshi Yamahata from Kagoshima University Hospital, Japan, and he will share about his experience in neurosurgical spine in his center. And second, we have Dr. Ajit Risdianto. Unfortunately, he could not join us now. I hope that
Maybe later.
maybe later he could join us in this discussion. And Dr. Ajit is doctor from Karyadi General Hospital, Diponegoro University. And also in this discussion, we will be led by Dr. Yuris Bahtiar from Karyadi General Hospital and Diponegoro University. And in this discussion, if you have any question regarding the presentation that will be presented by the speaker, please do not hesitate to ask in the chat box. You can ask in English or in Indonesian, and we will help your question will be translated to English as well. So without further ado, I will please welcome our moderator today's evening, Dr. Yuris Bahtiar. Please, time is yours.
Good afternoon, good evening, Dr. Yamahata Hitoshi and other participants. Here we have Dr. Pandu Wicaksono and another senior of neurosurgery in other town. Now we will have a lecture from Dr. Hitoshi Yamahata, MD PhD from Kagoshima University Hospital. I would like to introduce you about him. He was have a medical doctor from Kagoshima University, Faculty of Medicine in Kagoshima, Japan, and got a PhD in Graduate School of Medicine, Kagoshima University, Kagoshima, Japan also. We have a lot of important history from nearby hospital of Kagoshima University, and he is now as a lecturer on Department of Neurosurgery in Kagoshima University. He have a clinical specialist certified by Japan Society of Spinal Surgery, and he is now in membership of also in Japanese Society for Scalpes and also in Japanese Society of Spinal Surgery. He has an award of Kagoshima Neurosurgical Society, and in his research interest is in his topic is clinical and basic research in spine surgery. He have a lot of publication on that, and now he will give a lecture about the surgical management on spinal tumor. Please, Dr. Yamahata Hitoshi. Dr. Hitoshi Yamahata, and time is yours. You can start your lecture, and we will try to catch the question from the chat. Please, time is yours.
Good evening, ladies and gentlemen. Dr. Yuris, can you see this slide? Can you see the slide?
Not yet.
No?
Maybe another have, not yet.
And please wait here.
Dr. Yamahata, can you? Okay. Welcome, Dr. Happy Kurnia.
Okay.
Hi, Deiru.
Can,
Ada
can you
juga
see
ada
that?
yang says.
Yeah,
Can you
yeah, I
the
can see
slide?
your
Okay.
slide.
Okay.
Okay.
Good evening, ladies and gentlemen. My name is Hitoshi Yamahata. Thank you very much for the opportunity of presenting today's lecture. This is my self-introduction. I graduated from Kagoshima University in 1995. Since then, I have been working at Kagoshima University Hospital and affiliated hospital. My responsibility is skull base and spine surgery. Central nervous system is composed of two main structures, brain and spinal cord. Spinal cord is continuous from brain. However, there are several different points between the brain and the spinal cord. First is its size. Brain is far bigger than spinal cord. The second is their surrounding anatomy. Brain is protected by one cranial bone. The spinal cord is covered by vertebral body and disc and ligaments. Most intracranial diseases occur intradurally. On the other hand, spinal diseases are occasionally derived from the extradural region. In the operation, reconstruction of the cranial bone is simple cranioplasty. Spinal reconstruction is more complex than cranial bone. Because vertebral body and intervertebral facet is affected by load, we have to consider their reconstruction carefully by using several instruments. Therefore, simple posterior laminectomy is usually used for intradural disease. Brain has several characteristics in which spinal cord does not have. Here is the intraaxial mass in the basal ganglia. We have to examine its pathology. After the craniotomy, brain tissue can be retracted and biopsy will be done after incision of the insular cortex. In case of the spinal tumor, we have to pay a great attention during the retraction of spinal cord. This is another case. The intraaxial mass located in the temporal lobe. We can remove the tumor as lobectomy with preserving adequate area. However, there are so many functioning compartments in the spinal cord. We cannot enter into the spinal cord without disturbing functions. As stated above, the operation of the spine and the spinal cord is not easy. Anatomical knowledge, surgical skill, and neuromonitoring is necessary for successful operation. Spinal tumor can arise from spinal cord, surrounding left meninges, and extradural vertebral body. Spinal tumor are an uncommon disease. The incidence of spinal tumor has been reported that 1 to 2 patients per 100,000 people per year. In Kagoshima City, for example, 6 to 12 persons per year. In your country, Samaran, 16 to 32 patients per year. You have to operate this patient per year. Spinal tumors are rare disease and affect only a minority of the population. However, these tumors can cause significant morbidity. Neurosurgeons must face them and treat them carefully. Spinal tumor can be grouped into 3 categories: extradural, intradural, extramedullary, and intramedullary by its location. The frequency of spinal tumor is 60% for extradural, 30% for intradural extramedullary, and 10% for intramedullary tumor. In the Kagoshima University Hospital, tumors inside the spinal canal are mainly treated at our department. And orthopedic surgeons generally take care of tumor outside the spinal canal. This is our clinical result over the 20 years. This chart shows the frequency of the spinal tumor. Majority is intramedullary and intradural extramedullary tumors. We have 8 patients in 2019, but the number is much less than number of brain tumor. I'd like to talk about spinal tumor according to their category. The first is extradural spinal tumor. 60% of the spinal tumor are located in the extradural space. There are two subgroups, primary and secondary. Primary tumor of the vertebral column are uncommon as compared with secondary metastatic disease. Primary tumor of the vertebral column are rare. However, there are so many pathological diagnoses. They are classified according to their malignancy. Among the primary tumor of the vertebral column, hemangioma is the most frequent primary tumor. It is sometimes detected in asymptomatic patients. Although rare, follow-up MRI demonstrated the enlargement of the tumor and deformity of the thoracic spine. You better memorize the vertebral hemangioma can affect spinal cord like this. Metastatic spinal tumors are most frequent. They are derived from lung, breast, prostata, kidney, or other organs and cause back pain as well as myelopathy. Metastatic spinal tumors sometimes cause erosion of the pedicle, leading to pedicle sign on the X-ray. Scintigraphy or PET study is useful for detection of the metastasis. Usually, a spinal tumor shows hypointensity in the T1 weighted image. Infection and fracture also show hypointensity in the T1 weighted image. Differentiation is important. Treatment is depending on the patient condition, performance scale, and its origin. This is a representative case of extradural tumor, 87-year-old man with lumbar pain, general fatigue, and gait disturbance. MRI showed a hypointensity multiple and slightly enhanced, and bone erosion is here. Diagnosis of metastasis from prostata. This patient underwent chemotherapy and radiation therapy. Then next to the intradural extramedullary tumor. It accounts for the 30% of spinal tumor. Depending on the location, the tumor causes several symptoms. Schwannoma and meningioma are two major pathologies. In Japan, schwannoma is more frequent than meningioma. Spinal schwannoma is most frequent tumor. They usually arise from dorsal nerve root. Some case looks like a dumbbell shape. T2-weighted image in mixed intensity and heterogeneously enhanced. Like a vestibular schwannoma in the posterior cranial fossa, spinal schwannoma can cause hydrocephalus. The origin of the schwannoma is considered to be one rootlet. To remove the tumor, we have to cut the proximal and distal rootlet. In some cases, tumor contains the plural rootlet. We have to preserve normal rootlet other than the tumor origin. This is a representative case of schwannoma, 28-year-old woman with light sensory disturbance. At T4 level, a round mass. Because the tumor located dorsolateral, we planned a muscle-preserved hemilaminectomy. First, spinous process was longitudinally cut, and one side was retracted, and hemilaminectomy followed by tumor removal was done, and wound was closed. This is the operation video. The patient was placed in a prone position, and this is a T4 level using X-ray confirmation. First skin was open, and the spinal process was longitudinally cut by sagittal saw. And the left side was retracted. This is the microscopic view. Operator was standing in the left side of the patient. This is the left side. Hemilaminectomy was done by high-speed drill. Gentle palpation confirmed the hard mass under the dura. Then open the dura. We can identify that round mass. It looks like a schwannoma. Electric stimulation confirmed that there are no response of the muscle. After the confirmation, the internal decompression was done. A small piece are sent for frozen section. Internal decompression by QSA. After the decompression, we can identify the proximal root red. There are no response. Then coagulated and cut. Usually root go outside. Then this is a distal end. Distal end several roots that contain the tumor mass. This is the distal end and coagulated and cut. Then tumor was removed in block fashion. This is the spinal cord and the dentate ligament. The remaining part is carefully coagulated. This is the last picture of the operation. Post-operative MRI showed a gross total removal. Schwannoma can grow dumbbell shape. This is the Eden classification of the dumbbell-shaped tumor. Treatment of this type tumor needs another method. This is the representative case of dumbbell-shaped tumor. 72-year-old woman with left shoulder pain and left hemiparesis. C12 level, right side, left side. The prone position, the skin was open. This is the picture show the C1 and the C2. Operator standing in the left side of the patient. This is the tumor here. Then partial C1 laminectomy was done. Then here is a dural sac tumor. The first internal decompression was done like this. Then now we remove the extradural portion. Then here we have to check the intradural portion. The dura was inside. This is the inspection shows multiple C2 root red with intradural mass. Here, this schema shows the dumbbell-shaped mass. They all coagulated root. We cannot preserve this root red. They all coagulated and dura was cut like this. Then intradural portion was removed. Then subcutaneous fascia was patched. Then extradural portion was gross totally removed. This is a post-operative MRI. We next move to the spinal meningioma. Characteristic of spinal meningioma is almost similar to that of cranial meningioma. Female predominances, calcification on CT, and dural tail sign. In the MRI study, schwannoma and meningioma look same. Differentiation of these tumors from signal intensity alone is often difficult. Dr. Yamaguchi investigated the characteristic sign of spinal meningioma. The axial image shows that meningioma compressed the spinal cord. This compressed spinal cord looks like a ginkgo leaf, which is specific for meningioma. This sign is useful for the diagnosis of spinal meningioma. Removal of the spinal meningioma is similar to that cranial meningioma. Simpson grade 1 removal is ideal goal. However, the tumor occasionally locates at the ventral side and normal structure disturbs the visual field. I think removal as much as possible and coagulation of remaining parts seems to be enough for the spinal meningioma. This is a representative case, 76-year-old man with neck pain. MRI disclosed the foramen magnum meningioma. This is a foramen magnum meningioma is slowly growing tumor and make a space by compressing the spinal cord or brainstem. In the previous hour study, we divided these three types, clival type and foraminal type and atlantal type. Type B and type C has wide operation field. Therefore, the complication rate is significantly smaller than type A. This is the operation video. Patient was placed in the right lateral position, park bench position. The dura was opened. This is the spinal cord and the tumor. At first, internal decompression was done. Here is a 11th nerve, C1 root. After internal decompression, circumferential dissection. Here is a 12th nerve. This is a detachment. Tumor was removed en bloc by two pieces. Two pieces. Here is the dura coagulation. This is the final view of the operation. Postoperative MRI confirmed the gross total removal. This is a photography of a nice guy. It taken in the 2010 at the Saga Medical University. Here's a Dr. Yuritz and he's a Dr. Bohara from Nepal. We went to the famous Professor Lawton to take a lecture of the neurosurgical anatomy. It's a very good special experience for us. The last part of today, intramedullary spinal tumor. Intramedullary spinal tumor is rare, but I think this is most challenging tumor. Ependymomas are the most frequent intramedullary spinal tumor, followed by astrocytoma and hemangioblastoma. To remove the intramedullary tumor, we have to enter the spine into the spinal cord. There is a lot of functioning area in the spinal cord. The entrance is important for preserving its function. The location of the intramedullary spinal tumor is divided into three types: central, lateral, or subpial type. Dr. Takami classified the approach central type for posterior median sulcal approach. lateral type, a posterolateral sulcal approach, and subpial type for direct transpial approach. Spinal ependymoma is a slowly growing tumor. They are usually accompanying a cyst formation. Operative photo shows a clear shifts near the tumor. This is representative case, 76-year-old woman with left sensory disturbance. This is the operation video. Patient was placed in a prone position and laminectomy 3, 4, 5 was osteoclastic plastic laminotomy. This is the dura mater. And dura was open. Here we can see the spinal cord covered by arachnoid membrane. Arachnoid was cut. Usually we tenting the arachnoid bilateral side. We have to check the midline. This is a longitudinally vein. This is the posterior midline sulcus, and cut the pia mater, then gently open the midline. Brown colored tumor was, we can identify the tumor. The small cyst was caudal side and rostral side. Here the tumor. It looks like ependymoma. The small piece was sent for the frozen section, and internal decompression was done. This is the caudal side. After the decompression, from the caudal side or rostral side, tumor was separated from the ventral side of the spinal cord. This is the rostral side. Ventral side spinal cord. Slowly lift it up. And internal decompression. Occasionally, small vessel enter the tumor, then the coagulation. Almost the last piece. This is the gross totally removed the ependymoma. And pia mater was closed by nylon and dural closure. This is the post-operative MRI show the gross total removal. Spinal astrocytoma, a second common intramedullary tumor. In some cases, hyperintensity T2 weighted image, but there is no enhancement. This is another astrocytoma, T2 hyperintensity. This patient showed an irregularly enhanced mass. They are infiltrative character. Therefore, gross total resection is difficult. This is representative case. A 68-year-old woman with progressive gait disturbance, urinary incontinence, and sensory disturbance. Teeth-weighted image showed a long, irregularly mass and irregularly enhanced. In the prone position, we opened the skin and laminectomy was done. Spinal cord was swelling and open. The tumor was identified, but differentiation between the spinal cord and tumor was difficult, and a partial removal was done. Diagnosis is a glioblastoma. This patient underwent chemotherapy and radiation. This is a conclusion. Spinal tumor are an uncommon disease. However, they can cause severe problem. Surgical removal is a definite treatment for cure. Microsurgical skill and anatomical knowledge is mandatory for good clinical result. Thank you for your attention.
Okay, thank you very much for your lecture, Dr. Yamahata. It's nice presentation, it's nice operations, and it was clear operation, I think. And maybe the next presentation should be Dr. Ajit, but he have another operation in OR because of some because of length of the operation time. So maybe is there any question from the audience? Dr. Happy, are you here?
Yeah, I'm here. I'm here. I still here.
How are you, Dr. Happy? Are you? You feel good?
I'm still in my bed. How do you do, Dr. Yamada? Nice to meet
Hello.
you again.
Good evening. You are now lying in bed, on bed?
Yeah.
Yeah,
because
because
my
of
back itch.
Why?
low back pain.
Low back pain. It's very painful.
Well, really?
Now, today I'm a patient about the low back pain, and then I saw and then I feel how to patient back pains. It's many it's many how to pain about this and the back pain, and many medicine cannot be distinguished about my illness. I need more morphine, and then and I
what? You took MRI?
Yeah.
Lumbar?
Yeah.
There are no abnormal region?
It's a normal. It's a normal. My lumbar is normal. But my fascia on the paraspinal is tearing in there because my activity and then
I understand. Maybe to 1 week, after 1 week, you will get better.
You have to take a bed rest. Yes. Dr. Yuris says today is my doctor. I have a patient now.
Okay. Dr. Ajit is coming, so maybe he will give a lecture after he preparing the laptop. And I have one question to Dr. Yamahata.
Yes.
About the assay on the spinal AVM. Do you have any experience of the spinal cord AVM?
AVM.
Yeah.
Spinal AVM has a 3 category. Maybe you know spinal AVM and perimedullary arteriovenous fistula and spinal dural arteriovenous fistula. You mean the spinal AVM or
yes.
other 3?
Spinal AVM.
Spinal AVM is so rare disease. I have never encountered the true spinal AVM. I'm very sorry.
But do you do the surgery on spinal AVM or no? In
Yes,
other
I have a treatment experience of the spinal dural AVF.
spinal dural AVM?
Spinal dural AVF.
And how to do the diagnosis of this of the AVF? You will do the DSA or you will do
First is
the
the
MRI
MRI
only?
study, MRI study, then CT angiogram.
Oh, CT angiogram.
CT angiogram is very useful. After the spinal angiography is relatively invasive to the patient because so many segmental artery. We have to check every segmental artery. So at first you confirm the almost level lumbar or thoracic or by CT angiography. Then you proceed the DSA.
Oh, okay. Thank you very much. One question from Dr. Krishna. He is a neurosurgeon also. And in intraaxial cases,
Yes.
astro or ependymoma, is suturing the pyometer necessary?
Excuse me. Hi.
Is suturing the pyometer
Pyometer. Yes.
is necessary?
No, not necessary. But it is if the PIA is open, postoperatively spinal cord is attached to the dura. But adhesion. So adhere is
addition.
Yes, I'm worried about the adhere with spinal cord and dura. So we close the PIA.
Okay, thank you.
Not so difficult.
Okay, thank you. Here we have Dr. Ajit. Are you ready? Dr. Ajit.
Okay. I'm ready.
Okay, Dr. Ajit. So I will introduce a second speaker. He is a spinal surgeon in neurosurgery department of Diponegoro University and Karyat Hospital. He will talk about the cervical spine trauma. I think trauma and cervical spine. Please, Dr. Ajit, this time is yours.
Okay, thank you. Hello, everybody. Good afternoon, Dr. Yamata Sensei. It is nice meeting you today.
Thank you very much.
I hope we can learn much from you. So can you see my slide, Dr. Yuris?
Yes.
Okay. Give me a minute to show all. Okay. Today I'm going to talk about subaxial cervical spine injury, not all about cervical injury, but only a group. It is subaxial cervical spine injury. Thank you for everybody that have contributed to this slide in all of the neurosurgery department staff and also for the resident. My name is Ajit Isyanto, but I'm interested on focus in spine surgery. Today, the overview of this presentation is, the first is anatomy and physiology, and then injury mechanism, therefore pathology and management of the cervical spine. Just for starting, this is the cervical spine. We know the biggest one is the axial, this level, and we have C3, 4, 5, 6, 7 cervical. It is called as axial, subaxial level of cervical, consists of C5 till C7. In the between of the corpus, we know it is consists of discus, and in the anterior part of the corpus, we have anterior longitudinal ligament. In the posterior part, we have posterior longitudinal ligament, and canalis spinalis that consists of durameter, arachnoid diameter, and also spinal cord, and also the radix. In the posterior part, we have spinous process, lamina on the lateral side, and join as a facet superior that join with the inferior facet of the upper part of the vertebral body. Between spinous process, we have interspinous ligament that very important in posterior veins, and also supraspinous ligament. This is run in here from cranial to caudal. So in injury, it is very good if we have understand about injury mechanism, mechanical injury, because if we understand the mechanism injury, we can imagine what happened in the cervical, what happened pathology that we can find on the level of the cervical. Some mechanism have proposed to help us to understand what kind of pathology that will be found in the level of the cervical. It is very good to understand that it consists of three kind of mechanism of injury. The first one is axial loading from the upper cervical in neutral position. The second mechanism is flexion injury. This is the force coming from the posterior, maybe in this side, and make a rotation to the anterior side. And the second one as extension injury, or somebody call as hyperextension. Allard and Robertson has combined these three basic mechanisms with the flexion plus rotation, extension plus rotation, and also axial loading with flexion. With that combination, we have hyperflexion injury, hyperextension injury, vertical compression or axial loading, lateral flexion, and others. If we have understand about this basic anatomy of cervical spine, if there is some hyperflexion of the head and cause the cervical injury, there is some injury in the anterior part or anterior side of the cervical level. And also the distraction of the posterior, because the rotation to the anterior will make compression in the anterior and luxation or distraction in the posterior side. So the pathology that we can find in the hyperflexion, the first one is hyperflexion sprain, and bilateral interfacet dislocation, simple wedge compression fracture, clavicular fracture, or flexion tritral fracture. This is a very unstable fracture. And also unilateral interfacet. This is the little bit same mechanism with bilateral interfacet dislocation. In other group, Alec has divided the flexion injury with acting long. It is mean only flexion, hyperflexion injury, but he also combined with compression rotation and also with distraction. In compression and flexion, we can find anterior vertebral body kyphosis and disruption or of the interspinal ligament and also triptych fracture. On hyperextension fracture, we can see hyperextension dislocation, avulsion of the atlas, extension triptych fracture, lamina fracture, and also pillar fracture with retraction. In neutral position of vertical compression, we have Jefferson fracture in C1, but we did not discuss today, and also burst fracture in the lower cervical spine. Neutral position with compression in this diagram, we can find burst fracture. Okay, we are go to the vertical compression injury or axial loading in neutral position. It is purely compressive force in the cervical spine without flexion or extension. So the force is in here, coming from in the upper part of the head and make a compression or axial loading to the cervical. So it is basically, if we had a mechanism like this, it can be burst. The, the, the corpus is burst. So the pathology, we can find burst fracture in the subaxial level. See, 2, 3, 4, 5, 6. Like in this picture, we have burst fracture in the C6. Burst fracture are the most common with the possibility of the retroperfusion of bone into spinal canal that compress to the spinal cord and make neurological deficit that we can find with clinical finding. It is our case with compression fracture. We have C7, C7, C5 burst injury. We have sagittal fracture in here. But we cannot identify on MRI. As we know, MRI is not good to diagnose in bone injury. But when we have, but we find some spinal cord contusion in the level of C2 till C7. This patient have tetraparesia after fall from a height 2 meter with a motoric power average in 2 and 1. The other pathology is flexion injury of the subaxial cervical spine. It is posterior element fracture occur in 50% of the case. Subtype of this mechanism is teardrop fracture and quadrangular fracture. Some patient we can treat by mild cervical compression with rigid orthosis from 6 to 12 weeks. Stability is very good. It's must assess with flexion extension view before completely discontinue the breath. So if there is no compression, the second thing that we must check is stability of the cervical spine. If the stability is good, we can remove the breath after 6 till 12 weeks. The next pathology that coming from hyperflexion injury with compression is teardrop fracture. This is very unstable fracture that's combined of or result from compression of the anterior column, this side, and also the tension of discal ligament complex in the posterior part of the cervical spine. Result from hyperflexure with compression or axial loading to the vertex of the skull with the neck flex. Most severe form of this teardrop injury is the injury consists of complete disruption of all of the ligament, especially of the posterior ligament. The facet joint and intervertebrae disrupt and more than 3 millimeter up to 3 millimeter of spondyloptosis. We can, like in this picture, we know it is retroperfusion of the upper vertebral body to the inferior vertebral body that more than 3 millimeter. That we know in cadaver dissection, some writer found that retroperfusion more than 3 millimeter is in stable condition. The second important feature is displacement of the inferior margin of the fracture vertebral body posterior into the spinal canal. Like we found in this picture, it is inferior part of upper vertebral body compressed to the spinal canal. Usually unstable. And some literature, they describe if almost 100% of this case, the fracture is unstable, and mostly we found some neurologic deficit in this patient. Some possible finding in teardrop fracture, we can find a small chip bone, the teardrop just beyond the anterior inferior edge of the inferior vertebral body on lateral cervical X-ray, often associated with a fracture through the sagittal plane, the vertebral body, which can almost always be seen in AP view, maybe midline or center. The thin cut CT scan is more sensitive to find this pathology. A large triangular fragment of the anterior vertebral body, like this one. Other fractures through the vertebral body may also occur. We know we can find sagittal fracture in axial view. The fracture vertebra is usually displaced posterior on the vertebra below, easily appreciated on oblique X-ray. However, cases without retrolysis are almost also described. The fracture body is often wedge fracture or kyphosis in pathology and may also be wedged possibly laterally. Disruption of the facet joint, like in this case, this is facet, may be appreciated as separation of the joint on lateral, often unmasked by cervical section. Vertebral soft tissue swelling, we know in the anterior part of the vertebra, we can see prevertebral soft tissue, and most of the case found of prevertebral soft tissue swelling. And also narrowing of the intervertebral disc below of the fracture, that indicating of disruption of the discus. This is the scheme of the teardrop fracture. We found anterior part is wet, that also retroperfusion of the vertebral body to the inferior or upper superior side that compressed to the spinal column, and in the posterior we find the disruption of discal ligamentous complex. So this is very unstable fracture that we have to do something with this patient. One pathology that we saw differentiated from teardrop fracture is avulsion fracture. Avulsion fracture is only small bone chip that it is maybe a long bone chip that exists there before trauma, or only just small avulsion that due to the trauma. But in teardrop fracture, we can see that pathology is so many pathologies we can find there. Fracture of the anterior part of the cervical, corpus cervical, and also retroperfusion of the vertebral body that we can find as neurological deficit on clinical presentation. So, determining if the following criteria are met neurologically intact in avulsion fracture. Size of bone fragment is usually small in avulsion fracture, and no malalignment of vertebral body in the avulsion fracture. This is the criteria for axial fracture. But we should diagnose, or we should assess as teardrop fracture if we found some neurological deficit of the patient. The other pathology is quadrangular fracture. It is coming from hyperflexion injury. It is oblique vertebral body fracture passing from anterior superior cortical margin to inferior endplate, posterior subluxation of superior vertebral body of the inferior vertebral body, and also we find angular kyphosis, disruption of this anterior and posterior ligament. We can see with this pathology on MRI. This pathology require combined anterior and posterior fusion. The next pathology is distraction flexion injury, like rotation from the anterior part of the head to the cranial and makes a hyperextension injury. So distraction flexion injury. The first one is hyperflexion sprain, a purely ligamental injury that involves disruption of the posterior ligamentous complex without bony fracture. So we only find ligamentous injury on this patient. Instability may be considered when film are obtained shortly after the injury spasm of the cervical paraspinal muscle spleen, the neck, and prevents to flexion. For patients with limited flexion, a rigid collar should be prescribed, And if the pain persists 1 till 2 weeks later, the film should be repeated. This is some journal that they describe about hyperflexion sprain. Hyperflexion sprain can be managed as surgical or non-surgical. In this journal, they manage this patient with non-surgical. This is the first time after injury in the A, and B is the patient immobilized with rigid collar. After 4 months, the radiology is still the same, but after X year, there is a realignment of the 2, 3, 4, 5 on the 4, 5 cervical. So some treatment that we can do for the patient of hyperflexion sprain is depend on the clinical condition and also from radiographical finding that we can see on the patient. The second pathology, the next pathology is subluxation. This instability indicated ligamentous instability. If we find horizontal subluxation more than 3 millimeter or angulation more than 11 degree, we should think about instability for this case and no neurological deficit. The next pathology is log facet, or some literature write as facet jams. Involve disruption of facet capsule. Normally, facet inferior facet of the upper vertebrae is in the posterior part of the superior facet of lower vertebrae. In some hyperflexion injury, it will disrupt the facet joint that make the inferior facet jump to the superior facet, and the position is in the anterior part of the inferior facet. We call it as lockout facet or jump facet. It can be unilateral or bilateral facet dislocation. It depends on the pathology in the mechanism of injury. So we have unilateral lockout facet and bilateral lockout facet. 20% of unilateral lockout facet are neurologically intact. 37% have root deficit. 22% have incomplete cord injury, and almost 15% complete tetraplegia. Bilateral lock facet or facet lock occurs with disruption of ligamentum of aphyseal joint, ligamentum flavum, ligamentum longitudinal, and also interspinous ligament. It is rare, but most common we can found at C5, C6 level or C6, C7 level. Almost 65 up to 8 and till 87% have complete quadriplegia or tetraplegia. Almost 30 till 25% incomplete, and less than 10% are intact. Occur in 40 to 60% case of cervical trauma. The diagnosis of this condition is we can find on C-spine X-ray, both bilateral, unilateral facet or bilateral facet. And if we have CT, it is usually optimal to identify the log facet. Radiology finding in bilateral log facet on AP, we can found spinous process above the subluxation. This is the spinous process. It's very different in the normal level. This is G2, 3, 4, 5, 6 log facet. We know that spinous process in the C5 jump over to the spinous process in C6. And if we can make CT incision, CT cut on the facet, we also found that the facet jump in the inferior facet jump to the jump to the inferior facet jump to the superior facet. This is our case that we found 40 years old man fall from a height, which is CS15. We know that the motoric power average 4 in the right and left in the superior and inferior. On X-ray, we've known that C2, 3, 4, 5, 6, 7. And C6 and 7, we know that inferior the spinous process jump over to the inferior spinous process. This is facet, superior facet or C6 superior, and this is the C7 facet. Normally, the inferior facet, the position is in the posterior of the inferior facet. But in this pathology, we know that superior facet jump to the anterior side of the inferior facet. So we call it, we diagnose this patient with facet lock. So after we have the pathology, we understand about the pathology for the patient. As a doctor, we should manage for the patient. The choice, the treatment for the patient is conservative or non-surgical, and the second one is surgical therapy, surgical treatment. Non-surgical treatment consists of immobilize and reduce externally. The surgical treatment is mainly consists of two things. The first one is decompression of the spinal cord, and the second one is stabilization of the cervical injury. We have to make a decision. There is some instrument that have proposed to help us to make a decision whether we do surgical or non-surgical treatment for the patient. One of the most instrument that widely used is SLIC scoring system or subaxial cervical injury scoring system that consists of three things. The first one is injury morphology, second one is discal ligamentum compact integrity, and the last one is neurological status. This is the diagram of the SLIC or 6 score. The injury, we can do the morphology. If there is no abnormality, the point is nil. And the worst thing, rotation, we have point 4. After that, we can examine the discal ligament complex. Is it intact or indeterminate or disrupted on the posterior side? And the last one, we examine the neurological status, intact, root injury, or complete spinal cord injury, or incomplete spinal cord injury. And then we sum the point of these three things, and we have the SLIC score between 1 till 3. It is non-surgical management. More than 4, we have to do surgical management for this patient, and 4 we not specified, but and depend on the clinical condition of the patient. So using this LSIC, we should know the spinal level of the injury and SLIC morphology, description of the bone injury, discal ligamentous complex, mostly in the posterior side of the cervical, and neurological status or clinical presentation of the patient, and also confounder factor that happen to the patient. Stability is the second that we must think. It is if we know we cannot find some neurological deficit, but there is some instability, we have to do something. A conceptual definition of clinical stability is coming from White and Punjabi that widely used in spine word. They describe as the ability of the spine under physiologic loads to limit displacement so as to prevent injury or irritation of the spinal cord and nerve roots including cauda equina, and to prevent incapacitating deformity or pain due to structural change. So if the loading is normal, the movement is normal, and we find some complaint of the patient, maybe it's we can find some instability for the patient. So one of instrument that can use to assess the stability is like it's this diagram. The term is anterior element unable to function, posterior element, and also about the nerve root rhythmic, abnormal tissue narrowing, and also dangerous loading that should be anticipated. And also radiographic criteria. In neutral position, sagittal placement 3.5 millimeter is coming from some journal, or some angulation that more than 11%, or flexion extension which on X-ray. If we cannot find some this point in lateral position, and if the patient is okay, we can do flexion extension injury with same criteria. But on sagittal pentose rotation, more than 20%. If we found something on there, maybe there's some instability for the patient, and we have to do something. After we have a decision, surgery. What is the goal of surgery? It's something we have as a neurosurgeon, as spine surgeon, to think about what we are doing with our patient. What is the goal of surgery? The goal of treatment of subaxial cervical spine injury, including early decompression of the spinal cord and nerve root when indicated on clinical finding. The second one, restoration of spinal alignment. The third, stabilization of the spinal column, minimization and appropriate management of adverse event, and early patient mobilization and early rehabilitation for patient. Surgical treatment, including anterior and also posterior approach. The choice of technique depends on, usually for the trauma patient, consists of anterior approach or posterior approach. In the choice of technique, as the treatment should tend to counter the instability and ideally should not compromise structure that are still functioning. In the absence of bony cushion or mechanical subaxial C3 till C7 injury or fracture device will eventually fail. So it becomes a race between fusion and instrument failure. Extensive injury, including trilateral fracture or compression fracture, may require anterior and posterior approach or combined approach. If we choose posterior immobilization and fusion, the indication is the procedure of choice for most flexion injury, useful when there is minimal injury to the vertebral bodies, and in the absence of anterior compression of the spinal cord and nerve, including posterior ligament stability, traumatic stabilization, local facet, and simple wet compression pattern. The most common technique that used for posterior fusion is lateral mesh screw followed by decompression of the lamina. If anterior approach we choose does not depend on integrity of posterior element to achieve instability. The indication are fracture vertebral body with bone retropulse into spinal canal, or we can find impulse fracture, mass extension injury, severe fracture or posterior element that preclude posterior stabilization and fusion, and may be used for traumatic subluxation of the cervical spine. Anterior approach usually consists of corpectomy and fusion. Corpectomy used as decompression for the decompression of the spinal cord. Fusion, we can use structural fusion or some implant that we can use to the patient. The anterior cervical decompression, fusion, and pattern, the advantage are surgery if the supine position which avoid the necessity of turning patient with unstable injury to the prone position. Direct exposure to the ventral spinal canal for decompression with high arthrodesis rate and the ability to restore segmental lordosis. But some disadvantages from the anterior approach include biomechanical inferiority of anterior fixation compared with posterior fixation, approach-related adverse event and including dysphagia. Pure outcome with anterior fixation is used without posterior stabilization in injury with end plate compression fracture or with disruption of the posterior tension band or unreduced facet dislocation. Posterior screw with root instrumentation and fusion. The advantage are biomechanically superior implant construct, the ability to directly reduce the facet dislocation or some pathology that we can find in the posterior side of the cervical. The opportunity to directly deconstruct of the posterior tension band, but there is some disadvantage. The first one is we should do in prone position, the inability to direct to compression of the anterior pathology like disc herniation, a higher incidence of wound implication, wound complication compared with anterior approach. Circumferential or anterior posterior approach sometimes we use for the heavy pathology of the patient. Indicated for treatment compact injury like in trigeminal fracture. This is the last one. This is our case, man with 49 years of motoric accident 2 weeks before admission with CS15 with motoric 4 in the superior and inferior level. On X-ray, we can find subluxation of C2, 3, 4, 5. The transaction is more than 3 millimeter. So it is unstable. And on the MRI, we can find that retroperfusion or subluxation of the C4-5 that compress to the spinal cord and some hyper intense on the spinal cord that correlate with the clinical finding. So this patient should be assessed. We can assess with SLIC, the morphology. This is distraction injury. The discal ligamentous, we don't know. We don't know exactly what happened, but maybe indeterminate. Okay. This patient condition is incomplete spinal cord injury. So the point is 4, 7. More than 5 is surgery. So we manage this patient with surgery. Our treatment, our choice is posterior approach because maybe there is some pathology, and during surgery for this patient, we know we can find that fracture of the lamina and also disruption on the facet. And we do lateral mass and rod construction and also decompression of the lamina and also correction of the luxation of the C4-5. And this is now we can find on SNP this is alignment of the C4-5. So as a conclusion of my presentation is basic anatomy of cervical spine is very important to understand cervical injury. An understanding of mechanical injury of cervical trauma help us as a doctor to understand pathological condition in the cervical after injury. Assessment of the clinical and radiographic condition are very important to decide treatment choice for the patient. In patient for whom surgery is indicated, decompression and stabilization for the patient should be considered. Thank you, Dr. Juris. Thank you, everybody that has joined with us today. And also Yamata
Thank you very
Sensei.
much.
Thank you. Thank you very much.
Okay.
Dr. Rajit. Is there, we have questions, I will read the question first for Dr. Yamahata. Dr. Yamahata?
Yes.
Okay. So, dear Prof. Yamahata, this question from Mr. Zuhra Ma'ruf. Dear Prof. Yamahata, I have a question. Does the metastatic spinal tumor need operations, and and what are the indications of surgery? Is it dependent on pathological of primary tumor?
Kurang makan, dehidrasi dan lain sebagainya.
Alhamdulillah.
Dr. Yamahata?
Yes.
Maybe you can read in the chat group.
Chat?
Question you can read on the chat. Yeah, chat. You can open the chat.
Yes, I opened the chat.
Yeah. And then you can in the fourth from Zuhro Ma'ruf.
Zuhro Ma'ruf.
Dear Professor Yamahata, I have
Metastatic
question. Does the metastatic spinal tumor need operations? And what are the indications for doing surgery? Is it dependent on particular family?
This is not easy for the indication choice. It depends on the origin, or lung carcinoma, or prostata, or thyroid, or mamma, and maybe we have to discuss the doctor at the department, and it depends on the patient condition.
So you mean that mostly it depends on the patient's conditions and it depends on the pathological of primary tumor?
Yes.
Okay. Another question, Yamahata Sensei.
Yes.
An interesting case is about spinal GBM on your presentations. Did you also perform chemo as well as radiation therapy for adjuvant in that case?
Yes. Our treatment protocol is same as a brain astrocytoma.
So there are no differences between the spinal and brain?
Yes.
Okay. Another question maybe for Dr. Ajit.
Yes.
What from Dr. Krishna? What do you suggest about timing of decompression surgery in acute cervical spine injury? Should we manage it as an emergency surgery, or should we manage until sometimes for its edema reduction or spinal shock?
Thank you, Dr. Rish. Thank you, Dr. Krishna. We can divide this patient condition into condition. The first one in the incomplete lesion, like ASIA, E, D, and C. C and D. We can find it is as a incomplete lesion. So the surgery is in the early condition is very good to preserve the neurological deficit and to improve the neurological finding. And the second condition in patient with complete lesion. Complete lesion we can divide as spinal shock condition, and the second one in non-spinal shock condition. Some literature said that with patient in complete lesion and without spinal shock condition, and the ongoing spinal cord compression and the purple cavernous reflex extraction, the patient may be in, if we do surgery as soon as possible, maybe the improvement is nil, or there is no improvement. But some advantage that we have, that we can reach of the surgery is early mobilization. So if the patient is safe to do surgery, some literature propose or suggest surgery. Usually 4 till 5 days after the injury and the patient is safe to do surgery, surgery is recommended for this patient condition.
Okay, Dr. Ajit, thank you very much. I think we have questions from Dr. Rizky Yulianto. Maybe you can have opinion about the steroid medication in spinal tumor, in spinal trauma. Should we give the steroid medication in spinal trauma, or maybe should we give also steroid on spinal surgery, after spinal surgery or tumor spinal surgery? Please, maybe from Dr. Ajit first, and then Dr. Yamahata will have another opinion about the steroid medications?
Steroid is very controversial till now. There's some research about this, the use of steroid, and some literature said it's positive, some literature it's not no useful using steroid. So I have read about one literature that they say if steroid used in incomplete patient, 1 year later there is some improvement in the group of the steroid compare with the non-steroid use, but also accompanied with the decompression and also stabilization as indicated for the patient. Maybe Yamata Sensei have another reason why steroid is important or not.
Yeah, yes, I agree that Dr. Ajit's opinion, the use of the steroid is not controversial. We eh, we sometimes spare the use of the steroid because steroid cause a lot of side effect. So we didn't use routine steroid.
So you don't give a routine steroid in your post-surgical treatment or maybe for the trauma?
Yes.
Excuse me, Professor Yamada.
Thank you.
A
Please,
question
Dr.
about
Happy.
this steroid, Professor. And then many literature from Europe. It is used. It is a use corticosteroid for spinal cord injury. Sometimes it give it a high dose and 8 hours of or name as a golden period. Are you agree or not about this literature like this? Some other give it give it a corticosteroid because this can reduce of the swelling of the spinal cord in there. And this doesn't make a confuse. And in there, on the ATLS in the US, is not to give it the corticosteroid because it's corticosteroid is dangerous. And to give it a high dose, the fluid can go to the interstitial compartment and it go to the lung in here. But in the European, it give high dose on the golden period is make can make benefit about the medulla spinalis, and then in the cervical level, if can reduce about the swelling. How about your opinion, Professor Yamada?
The use of the steroid?
Yes, that's right. It's with the high dose.
Spinal injury?
Yes, that's right.
Yes, in acute
yes,
conditions.
maybe in Japan, most neurosurgeon and orthopedic surgeon do not use the steroid routinely.
Okay, okay. Not routinely. Sorry, it is not routine.
Yes, yes.
But sometimes they give it corticosteroid. That's right.
Maybe it's the doctor's preference.
Okay.
Maybe. There are evidence that the steroid is good, but there are other evidence steroid is not useful. Maybe you can get the PubMed.
Oh, okay, okay, okay.
Okay, Dr. Yamada, thank you.
And this is one question for you, Professor Yamada, about the symptom of the tumor, and then tumor extradural or intradural, or this is make a confuse. Some patient is only having a suddenly paralyzed or something as only illness like this. How about your opinion about this symptom? This is the first symptom about the can for give education the patient for beware about this condition, like illness or like numbness or like paralyzed. Be careful about this is a symptom of tumor. How about the opinion? But till now we can do that classificate about tumor extradurally or tumor intradurally and about the symptom. How about the opinion, Professor Yamada?
You mean the differentiation of the between the extradural or intradural with regard to the symptom?
Yes, right.
Yes.
Maybe this is very challenging to differentiate the from the only symptom by the but maybe in the I presented the one GBM case, glioblastoma. This is the GBM is a pathology, the malignant pathology. The patient's symptom is very rapid.
Yeah, that's right.
Rapid. Initial to only 2 or 3 weeks. This patient suffered paralysis. So, benign tumor shows slowly symptom change. But it depends on the pathology. I think extradural or intradural.
Yeah, that's right. I make a confused about some patient with the tumor. It came. We have to anamnesis. Suddenly, I have the paralyzed, can walk or can another moving, and then I think so. This suddenly it is the trauma or caused by vascular condition is suddenly in here, and then after look at the MRI, it is found this is a tumor extradurally, but give a symptom suddenly in there. I have to diagnosis and investigate with the patient, not gradual. The first maybe numbness or illness, and then the patient asked me about this. I have suddenly. Not to trigger anything. How about you in this case like this, Professor?
This is a very difficult to answer, but this patient maybe had a lumbar pain or back pain before the onset of the paralysis, maybe.
Yeah, that's right.
So tumor is rapidly or gradually enlarging, then cause paralysis. But I cannot answer.
I'm sorry, Dr. Yamahata.
Yes.
Could you differ the vascular event?
Excuse me.
Could you differ the symptom of vascular event on the spinal tumor? It means that vascular event is ischemic event, suddenly ischemic event on the spinal tumor. Could you differ that vascular event, vascular compression problem, compression?
Vascular compression due to the tumor that makes some pathologies on the spinal cord.
Yes, this is interesting.
Yeah.
Tumor compress the spinal vessel, then disturb the circulation, then subsequently cause the
sudden
myelopathy.
Sudden
This is a very interesting pathology.
Okay. A questions to Dr. Ajit, and maybe Dr. Yamasa also can give your opinion about this. How about the recommendation for the spinal cord contusion after stabilization of the patients? What is your treatment recommendation for your spinal cord contusions?
Actually, in all departments,
after stabilization.
Actually, in our department, we do not do something for the cervical contusion. We only do decompression. After that, we hope there is some improvement of the spinal cord. The function can improve and the clinical condition is better. Just like that, we do not give something for the cervical contusion. Maybe Yamata Sensei have any other recommendation for the cervical contusion?
Cervical concussion.
Contusion, contusion.
Contusion, cervical contusion.
With
Spinal contusion.
with bone fracture or without bone fracture?
They say, how about the cervical contusion after surgery?
Maybe without bone fracture or
after the case is after surgery. So what will you do for the cervical contusion?
We try HBO. You know HBO.
HBO?
Hyper
Yeah.
oxygen.
Hyperoxygen.
hyperbaric oxygen.
Hyperbaric. Yes.
Ah.
Yes, right.
Oh,
In some case,
become better?
yes. In some case, it is useful treatment. I think.
I think it's interesting. I will
Yeah,
try to find the literature.
Can try hyperbaric oxygenations. I remember that I read some preclinical study about the curcumin on intrathecal curcumin, but I'm not sure about that. But they try to give extract curcumin on the intrathecally. I don't know. This is they say that curcumin can improve the outcome, but we're not sure about that in human. But they try in mouse. Basically, they can have a result on the outcome, but I'm not sure in human. Do you think about? Do you ever read this, Dr. Yamahata?
Excuse me.
Do you ever read about the curcumin on intrathecal?
Curcumin means I don't know.
You don't know, okay.
Yeah, I don't know the curcumin. Excuse me. I'm sorry.
Yeah. Don't worry. Okay. Is there any questions for other presentation as the other presentant? Or maybe from Dr. Happy Kurnia? Or maybe also Dr.
One
Ajit
question
Ismail?
from Taufik Fatur Rahman about cervical traction, if there is some time.
Oh, yeah.
Yeah, of course, sir, they ask. He asked about cervical traction for unstable cervical injury. Of course, cervical traction is one of modality that we can use treatment to treat a patient with cervical spine injury. You can use cervical traction. One of the recommendation that you can use is rule of 10. It means that rule of 5, that one level of the cervical injury is the point of 5 pound. So the example, you have injury in C5, you can do maximal 5 cross 5, 25 plus 35 pound. So the maximal loading for the cervical traction is 70.5 kilogram. But you should do it gradually from the minimal, and then you can improve the loading. Maybe the next step is plus 1 kilogram, but you should monitor the vital sign of the patient and also the neurological condition of the patient, and also the X-ray, lateral or AP X-ray for patient with that you have performed cervical traction. Yeah, cervical traction is one of modality, but you should understand how to do cervical traction. Lateral condition, anterior side of the point or posterior side of the patient, and how many loading that you should use for the patient. Maybe Yamata Sensei have another suggestion to do cervical traction.
maybe I don't have any case of the cervical trauma. Maybe I chose the hello best, you know.
Hello Fest, yeah.
Hello,
Yeah,
Fez.
for the
Hello, Fez.
Hello Fest, yeah.
yeah cervical fracture before surgery.
Okay. Thank you very much. I think because of time, the discussion is also nice and got a lot of knowledge in spine surgery. And thank you very much for Dr. Yamahata, Professor
Thank you very
Yamahata,
much. Thank you very much.
and
Thank you,
also
Dr.
Dr.
Yamata.
Ajit for your nice presentation, and also our panelists, Dr. Happy Kurnia, and please you can join with us in our office because you can take rest for a while due to your low back pain. Anyway, uh, it's pity, but it's okay. Thank you very much, Dr. Yamata. Nice to meet you, and thank you very much, Dr.
Yuri.
Thank
Ajit.
you, Yamata Sensei.
We'll
Thank you, everybody.
bring it back to
Okay, see you, Dr. Yamada.
Dr. Park
See you.
as a host, please.
Okay, thank you, Dr. Yamahata, Dr.
Thank you.
Ajit, Dr. Happy, and Dr. Yuris. Okay, before we close this discussion this evening, I would like to ask participants to turn on their camera. And I also noticed that some of the participant is your ex-student in Kagoshima, Yamata Sensei. Maybe for us, please say hello to our sensei, Mas Dr. Ashari, Zia, Novita, Jacob, and everybody. Please turn on your camera so that we could take a picture together. Okay. Hello. Okay, please turn on your camera, and maybe some of you who knows Hitachi Yamata Sensei from Japan, please say hello
I
to
can
him
see
too.
the Ashari.
Okay, please turn on your camera, and I will take a picture. 3, 2, 1 from the first page, and next is okay. Once more, 1, 2, 3. Okay. Thank you everybody for your participation in this evening. And lastly, I also would say thanks for the speaker who has the time to sharing experience in this lecture.